Complications of pregnancy. The LPN must be able to recognize potential risk factors for pregnancy-related complications and know how to respond appropriately. The RN is going to oversee all the care, but the LPN also has to know those basics. In the past, women with chronic conditions were unable to become pregnant and give birth. But now there's new treatments that are available to assist with pregnancy. And the perinatologist, who is an obstetrician specializing in the care of at-risk pregnancies, has also improved the ability of these women to give birth. Chronic medical conditions and pregnancy complications are risk factors, and they can be interrelated. Pregnancy can affect whatever underlying or comorbidity they have had. The normal physiological changes of pregnancy can intensify symptoms of illness. Medical conditions can also affect the progress and outcome of the pregnancy, and chronic medical conditions of the woman can adversely affect the fetus. Excuse me. Pregnancy affects glucose metabolism with diabetes, which makes the disease challenging to manage. There's different types. We have pregestational diabetes where they were already diagnosed with it, and that's type 1 or type 2. We have gestational diabetes, and we have during pregnancy 3 normally occurring responses that can put women into a diabetogenic state, and that's hypoglycemia, hyperglycemia, and hyperinsulinemia. So with pregestational diabetes, once again, they have already been diagnosed with diabetes prior to pregnancy. They have a history of poor outcomes in the past, but improved outcomes with strict control of their blood glucose levels and fetal surveillance have improved those outcomes. If their sugars are poorly controlled, especially early in the pregnancy, they are at risk for birth defects, stillbirth, hypertensive disorder, polyhydramnios, which is extra amniotic fluid, preterm delivery, and macrosomia, which is a large fetus. Gestational diabetes occurs during pregnancy only, but it is similar to type 2. Risk factors include a history of a large for gestational age infant, previously having gestational diabetes, previous unexplained fetal demise, maternal age over 35 years, a family history of type 2 or gestational diabetes, obesity of being over 200 pounds, non-Caucasian ethnicity, fasting blood glucose over 140, or a random blood glucose of over 200. These women may not experience symptoms, so screening has to be done, and this is usually done at 24 to 28 weeks, but it might be done sooner depending on the circumstances. There is an increased risk of these women developing type 2 diabetes 5 to 20 years after delivery, and that risk is 50%. There are fetal complications from maternal diabetes. They have an increased risk for placental issues, fetal growth. The fetus can have hypoglycemia after birth, birth trauma, lung maturity issues, increased health risks later in life, and mom is at increased risk for cesarean delivery. The greatest risk is macrosomia, where the infants are over 8.8 pounds. Pre-pregnancy care, Women consult with the healthcare provider before becoming pregnant. Hyperglycemia is harmful during growth, especially during the first 8 weeks of the pregnancy, so they need to be well controlled. They need to obtain that state of euglycemia or normal levels before pregnancy. They should also be taking daily multivitamin supplements with folic acid several months prior to getting pregnant. Glycemic control. Pregnancy is going to cause periods of fluctuating energy needs, and pregnant diabetics should test their glucose levels more frequently. The goal is to maintain tight glucose control by monitoring their blood sugar by doing the finger stick testing or the hemoglobin A1C with levels less than 95 or not to exceed 120 2 hours after meals. Components to glycemic control for the pre-gestational diabetic include insulin, diet and exercise, and then diet and exercise for the gestational diabetic. Fetal surveillance with diabetes is a non-negotiable issue to help determine gestational age and size, fetal viability, structural defects, amniotic fluid volume, neural tube defects, and fetal activity. It's also important to determine the time of delivery because there's increased risk of delivery complications and fetal demise if that pregnancy progresses too long. And labor might be induced if the cervix is favorable and the fetal lungs are mature enough, but it can also lead to a cesarean section. Pregnancy complications from diabetes, pregnancy-related hypertension, preeclampsia, which are the headache, visual disturbances, epigastric pain, generalized edema, urinary protein, and elevated blood pressure. So again, glycemic control is very important. Gestational diabetes is a form of diabetes mellitus that occurs during pregnancy. It's caused by insulin resistance. What is the result of gestational diabetes in a normal pregnancy? This is mild hyperglycemia after meals. A priority of nursing care for any potential pregnancy complication is prevention of the complication. So the next complication is infectious disease. Once again, prevention is the best treatment. Important terms for you to be familiar with is immunoprophylaxis, which is prevention of disease by production of active or passive immunity. Perinatal or vertical transmission, which is transmission of the infectious agent from the mother to the child during the pregnancy, childbirth, or breastfeeding. Suppressive therapy, which suppresses but does not cure. And viral load. How much virus is in the blood? High viral loads equal increased symptoms. So then we look at the TORCH infections. The acronym for TORCH is toxoplasmosis, other, which is hepatitis B, syphilis, varicella, and herpes zoster, rubella, CMV, and HSV. All of these are teratogenic to the fetus. They cross the placenta, and the fetal effect will be determined by the gestational age at exposure. In other words, they're very harmful to the fetus. They're characterized by intrauterine growth restriction, microcephaly, hepatosplenomegaly, rash, thrombocytopenia, CNS findings, cognitive impairment, hydrocephalus, jaundice, hearing defects, and chorioretinitis. It can lead to spontaneous abortion, stillbirth, and/or premature delivery. So toxoplasmosis is transmitted through undercooked meats, unfiltered water, contaminated soil, and cat feces. Usually there's no symptoms, and it can be very difficult to diagnose. A newborn with congenital toxoplasmosis can present with chorioretinitis and hydrocephalus. So it's important to decrease the risk of infection, avoiding exposure to cat litter, wearing gloves when doing yard work, washing hands, ensuring that all meats are well cooked, and washing fruits and vegetables before eating. With the hepatitis B virus, again, this is transmitted sexually or through contact with blood or body fluids. Incidence has decreased due to immunization. People should be screened early in the pregnancy and at delivery for hepatitis B. If mom is positive, the neonate should receive a vaccine within 12 hours of delivery. All infants, however, should be given that 3-dose immunization series, with the first dose given shortly after birth. Syphilis is a bacteria that easily crosses the placenta. There's an increased risk to the mother of spontaneous abortion, fetal demise, intrauterine growth restriction, non-immune hydrops, fetalis, preterm birth, congenital infection, and neonatal death. Most infants who are infected are going to be asymptomatic at birth, but we may see some hepatomegaly, jaundice, snuffles, and long bone abnormalities. Screening of the mom is done early in the pregnancy with that RPR or a VDRL. If we do early treatment, this is a curable disease. And varicella zoster causes chickenpox. Herpes zoster causes shingles. Immunization has also decreased the incidence, but it's the highest risk if the woman contracts it during the second trimester. There's low birth weight, scar-producing skin lesions, limb hypoplasia, contractures, and can also result in damage to the ears, eyes, and CNS. If a pregnant woman reports exposure to the virus, she should have that serology test done to detect varicella antibodies and then be given appropriate medication. Best treatment? Prevention. Rubella is a viral infection, also known as German measles. Mom can have silent symptoms or a mild low-grade fever, rash, lymphadenopathy, general malaise, and conjunctivitis. For the fetus, we may see spontaneous abortion, stillbirth, preterm delivery, or congenital anomalies. There's no cure, but treatment will be supportive, and again, best treatment is prevention. The cytomegalovirus is another silent disease. Most people never even have symptoms, or they only have mild flu-like symptoms. It is transmitted through infected body fluids. Infection can be passed to the fetus, resulting in severe defects such as hearing loss, microcephaly, petechiae, seizures, small for gestational age, hepatosplenomegaly, jaundice, and rash. Again, there's no cure, so prevention is really important. And then herpes simplex virus, which is an STI. spread by direct contact. So there may be no or there may be painful lesions. The virus can go dormant after apparent healing and then return sometime later. The majority of neonatal cases are going to be due to exposure during delivery, exposure to a lesion in the birth canal. We treat with the cyclovir, which once again is an antiviral. It's not going to cure it, but it can reduce the incidence or reduce the severity and duration. It's also considered a suppressive therapy. These women may require a cesarean delivery if active lesions are there in the birth canal. So TORCH is an acronym for a special group of infections that can be acquired during pregnancy, and it's transmitted through the placenta to the fetus. Why is it so important to assess for TORCH during pregnancy? They are teratogenic. There are some age-related concerns that you need to be aware of. We know that typical childbearing years encompass age 15 through 44, although it can occur outside of those times. The woman can become pregnant anywhere from 9 to 56 years. Pregnancy carries a higher risk for morbidity and mortality at either end of the spectrum. These concerns are not necessarily pathophysiologic changes, but they're related to the condition of the reproductive system. So another complication is hyperemesis gravidarum. It is manifested with severe nausea, vomiting, dehydration, weight loss, electrolyte imbalance, especially hypokalemia, acid-base imbalances that occur in less than 2% of pregnancies. Now, don't confuse this with the more common morning sickness. Non-pharmacologically, we treat, if possible. Hospitalization may be required for dehydration. We can give medication or do some diet changes. So it's important to assess and document, decrease any trigger factors, assist mom with regaining her fluid balance, and obtain nutrition as needed, encouraging good oral hygiene, and also observe those family dynamics. Blood incompatibilities is the next complication. These are incompatibilities between mom and fetus that can cause problems for the fetus even though the maternal and fetal blood do not meet. They're usually related to trauma if the blood intermingles. There's also an increased risk during invasive procedures, active labor, early pregnancy loss, and placenta that separates at birth. Types of incompatibilities are the RH incompatibility or the ABO incompatibility. With RH incompatibility, we have an antigen on the surface of the blood cells. If mom is an RH negative individual and she's exposed to RH positive blood, she's going to start developing antibodies to fight that RHO antigen. When an RH negative woman carries an RH positive fetus, those antibodies cross the placenta and then start to attack the fetus, leading to hemolytic anemia in the fetus. It rarely happens today because of the administration of the anti-D immune globulin, also known as RhoGAM, within 72 hours after delivering the RH positive baby. Mom will also get a dose of this during the pregnancy. Clinical manifestations. Mom doesn't have any symptoms, but again, hemolytic disease in the fetus. So it's only a concern if mom is Rh negative, and mom has to have that signed informed consent before we can give RhoGAM. With ABO incompatibility, it's more frequently a problem if mom's blood type is O and the fetus is A, B, or AB, and it can result in a hemolytic disease for the fetus. It's usually not as severe as Rh incompatibility. The woman's immune system is going to produce antibodies to fetal blood, which cross the placenta and then attack the fetal blood. Neonates rarely require exchange transfusions, but will be likely to require treatment for jaundice. So, question. Although there's not a clear understanding of what causes hyperemesis gravidarum, several conditions have been linked with it. What is one condition that has been linked with hyperemesis gravidarum? And that's the molar pregnancy. Now, we talk about early pregnancy loss because this is something that we do unfortunately see. It is the most common complication of pregnancy. We have spontaneous abortion, also known as miscarriage, which is a loss of the pregnancy before the fetus is able to survive outside the uterus on its own, or 20 weeks. Risk factors include advancing maternal age, history of a previous early pregnancy loss, smoking, alcohol, substance abuse, increasing gravity. In other words, mom has had multiple babies, uterine defects and tumors, active maternal infection, intimate partner violence, and chronic maternal health factors. So if the spontaneous abortion happens early before 12 weeks, usually it's because something is going on with the fetus. If it happens between 12 and 20 weeks, usually it's something going on with mom. These women may experience cramping, spotting, or frank bleeding, abdominal and suprapubic pain that may radiate to the lower back, buttocks, and perineum, and they may also have fever and chills. As we talked about in a previous presentation, there might be threatened, inevitable, incomplete, complete, missed, or habitual. Table 17.1 talks a little bit more in depth about those different types of abortions. Treatment will depend on the type, but there's no specific treatment that can prevent loss. As nurses, we provide support, refer for grief counseling or a support group, and if the parents want, they should be allowed to see and or hold the fetus. Indomethacin is not commonly used because it can cause a reduction in amniotic fluid and can cause the ductus arteriosus in the baby to close prematurely, and that can cause fetal death. So these are some of those uterine relaxants that may be given if we are anticipating or mom is maybe threatening miscarriage. These are not the only ones, but they're some of the more common ones. So early pregnancy loss, commonly known as miscarriage, can occur for a variety of reasons. What is one of these reasons? And that is the active maternal infection. The next complication is placenta previa, where the placenta is implanted close to or over the cervical os, in other words, the cervical opening. As the pregnancy progresses, blood vessels in the placenta can start to rupture, and it causes painless bleeding. And that's important for you to remember, is painless bleeding. The exact cause is unknown as to why the placenta attaches low, but risk factors include history of elective abortions, multiparity, in other words, women who have had more than one baby, advanced maternal age, a previous cesarean birth or uterine incisions, maternal smoking, or a prior placenta previa. Again, painless bright red bleeding with no warning is a symptom. We should avoid digital cervical examination in these women. The fetus might become anemic, hypoxic, or hypovolemic if maternal bleeding is severe. Immediate cesarean delivery is required if that bleeding does not stop or if it's severe. Hospitalization with bed rest if the bleeding stops. We'll definitely do a non-stress test or continuous external fetal monitoring. And cesarean delivery is necessary for a total placental previa. So just some different pictures. And then we have abruptio placentae, or placental abruption, which is the premature separation of the placenta from the wall of the uterus. In other words, it separates before delivery of the baby, and it occurs in about 1% of pregnancies. The causes are unknown, but there are some known risk factors: hypertension, preeclampsia, pre-existing hypertension, advanced maternal age, multiparity, trauma, cigarette smoking, alcohol consumption, cocaine use, and that premature rupture of membranes. We have different classifications of abruption. It can be concealed or apparent. It can be partial or complete. So with mom, she can experience hemorrhagic shock, DIC, uterine rupture, renal failure, and death. With the baby, we see hypoxia, anemia, growth restriction, and death. So mom experiences pain. She may have dark red vaginal bleeding. She may not have bleeding if it's hidden. She can have a rigid board-like abdomen, hypertonic labor, fetal distress. An ultrasound may or may not help with diagnosis. So for mom, we're going to give her IV fluids. We may have to give her a transfusion, oxygen. An emergency cesarean delivery might be required. If bleeding is not controlled after delivery, she may require a hysterectomy. And for the infant, it depends on the distress and the symptoms that are seen. Another picture. So question, true or false? The nurse should be aware of potential causes of placenta previa and abruptio placentae, so both disorders can be identified early in the pregnancy to help with complications. This is false. One of the top 4 leading causes of maternal morbidity and mortality in the United States and in the fetus are hypertensive disorders. We have gestational hypertension, preeclampsia or eclampsia, chronic hypertension, or preeclampsia superimposed on chronic hypertension. So with gestational hypertension, it develops for the first time after 20 weeks gestation without the presence of protein in the urine. The blood pressure is equal to or over 140 systolic and 90 diastolic. It usually will resolve spontaneously after birth, and we call that transient. But if it continues 12 weeks after delivery, we now call that chronic hypertension. We monitor the protein in the urine and we monitor the client's blood pressure. We may give antihypertensives. With preeclampsia or eclampsia, this occurs in about 3 to 5% of all pregnancies. Preeclampsia is that elevated blood pressure, same parameters, with protein in the urine. Excuse me. It usually develops after 20 weeks of gestation. Eclampsia is the exact same as preeclampsia, but now we have seizure activity or coma. These syndromes can develop gradually or appear suddenly without warning, with an unknown cause, but it only occurs in pregnancy. Risk factors include a family history, first-time pregnancy or nulliparity, pre-existing medical conditions such as that chronic hypertension or lupus, renal disease, or diabetes, other obstetric complications such as a multiple gestation or molar pregnancy, erythroblastosis fetalis, or age, younger than 20 or older than 35. There are severe effects on both mom and fetus, so look at table 17.2 for all of those. There's no preventive therapy known to date, although aspirin can decrease a moderate to high risk women. There's no diagnostic test available to predict this, so it requires careful monitoring and early detection through regular prenatal care, which is the standard of care to help reduce morbidity and mortality. The primary problem is an underlying development through vasospasm and vasoconstriction, which leads to hypertension. This leads to a decreased blood flow to the organs, including the placenta, and that can also increase clotting. These moms will have the elevated blood pressure. They have protein in the urine, and that has to be documented. It's classified as mild or severe. A continued elevation of the blood pressure and protein in the urine, nervous system irritability, hyperactive, deep reflexes, clonus, severe headache, blurred or double vision, spots before their eyes, and nausea or pain in the epigastric region. These women can develop seizures with eclampsia. They have potential complications of aspiration, cerebral hemorrhage, stroke, hepatic rupture, abruptio placentae, fetal compromise, and death of the woman or fetus. Mom is going to remain at risk for seizure activity even in the postpartum period. Then we have the HELP syndrome, which is a severe complication of eclampsia. It involves hemolysis, elevated liver enzymes, low platelets. It's typically seen with severe preeclampsia. These women have have epigastric pain and tenderness, nausea, vomiting, Less frequently, they'll have visual disturbances and a headache. It, however, can be mistaken for the flu or other viral illnesses. Excuse me. Which can lead to a delayed diagnosis and treatment. Treatment of these issues: delivery of the baby, conservative management if it's just mild, which would include bed rest, limited stimulating environment, fetal kick counts, and amniocentesis, medication, monitoring those reflexes. Those reflexes are going to be hyper prior to treatment, and if we give magnesium, it's going to decrease reflexes. If they're toxic with magnesium, they'll be hypo. We want to prevent maternal seizures, provide bed rest in a darkened room. We give magnesium sulfate IV, monitor for signs of magnesium toxicity and oxytocin to induce labor. We may also give hypertensive medications, but they can be controversial because they can decrease placental perfusion. It's important to frequently monitor mom's vital signs, her lungs, weight, informing her of reasons for the treatment, and providing emotional support. Instruct mom what signs need to be reported immediately, the need for bed rest and lying on her left side, strict I&O, and adequate nutrition. If delivery is required for maternal or fetal well-being, we'll give glucocorticoids to the baby or to mom because it helps with the baby's lung maturity. We need to provide for psychosocial needs. In postpartum care, we're still going to be monitoring and teaching, and we may even continue magnesium sulfate for 1 to 2 days. Care of the infant is going to be really important because of side effects of magnesium sulfate. So let's talk about magnesium sulfate. Excuse me, RNs can administer this, but LPNs can assist with monitoring of the client. So you need to know about this. It's used in preeclampsia, eclampsia because it produces an anticonvulsant effect. It can also be used as a tocolytic, which once again causes uterine relaxation, to inhibit uterine relaxations in premature labor. Adverse effects: we have that loss of the tendon reflex. So we give magnesium sulfate IV. We have to use the electronic infusion pump and monitor vital signs frequently, doing an hourly assessment of output, protein levels, DTRs, edema, respiratory status. We discontinue it and call the healthcare provider if the reflexes are absent, respirations are less than 14, or urine output is less than 30. Fish and dairy down slightly in June from May. Airline fares actually falling 8%. Used car prices down. So question: which one of the first signs of magnesium sulfate toxicity, or one of the first signs of magnesium sulfate toxicity, is the absence of reflexes? This is true. So another potential complication is multiple gestation, which is more than one fetus per pregnancy. Twins are the most common. They can be identical or fraternal. There's an increase of multiple gestation with older maternal age, multiparity, or a family history. Mom has an increased risk for hyperemesis gravidarum, pyelonephritis, preterm labor, placenta previa, preeclampsia, eclampsia, postpartum hemorrhage, and anemia. The fetuses have a risk of being conjoined, having growth restriction, being born prematurely, or having umbilical cord prolapse. So mom is going to have a uterus that's large for her dates, anemia, fatigue, severe nausea, vomiting, or hyperemesis gravidarum. She should consult with a perinatologist, take the proper diet, multivitamins and iron supplements, rest. She'll be getting ultrasounds and more frequent prenatal visits, cervical checks, and weekly non-stress tests after a certain point in the pregnancy. And then the provider must choose the mode of delivery. They may try a vaginal delivery, but be prepared for a cesarean delivery. And cord prolapse. Just very briefly, this is where the umbilical cord delivers prior to the delivery of the fetus. So this puts extra pressure from the fetal head against the vaginal wall or the wall of the birth canal, and it cuts off the baby's circulation. So it leads to that cord compression, and it stops the flow of oxygen and nutrients to the fetus. Treatment requires relief of that compression and prompt fetal delivery. So now on to the post-test.